In the next 20 minutes or so, I'm going to briefly touch upon the role of CT and MRI and their relative advantages and disadvantages in valve imaging. Then we'll talk about the normal anatomy of the cardiac valves, and I'll discuss which planes are best suited for assessing specific cardiac valves. And finally, we'll talk about the spectrum of imaging appearance of valve abnormalities. And in the interest of time, I'm going to limit myself to native valves. So at the very outset, I'd like to say that echocardiography still remains the mainstay of valve imaging. However, CT and MRI are very good complementary techniques, and we use them a lot in conjunction with echocardiography. Now, for most practical purposes, and in my opinion certainly, I think MRI outweighs CT in certain respects. And one of the biggest advantages that MRI really has is the absence of radiation. Also, you don't need any contrast when you're doing, for most indications of valve imaging. So here is the image. It's a steady-state free precession sequence. You don't need any contrast. What MR does is that it utilizes the inherent contrast between the blood pool and the valve tissue and myocardium to produce these images. Also, it has a higher temporal resolution, though it does suffer in terms of spatial resolution. So how do we go about doing these scans? I'm not going to go into the details, but want to touch upon certain important aspects. So regarding the CT, like I said, it's got to be contrast enhanced if you want to see the valves. Secondly, it's got to be ECG gated. There have been very, very good talks in the morning and yesterday regarding the different kinds of ECG gating. But when you're doing a study, say, specifically for valve imaging, then what you want to do is a retrospectively gated scan, where you have data throughout the cardiac cycle, so you can reconstruct it in different phases and view it in the cine mode. Obviously, as you can remember, with retrospectively gated CT is the inherent penalty of a large amount of radiation dose. Moving on to MRI, and there are a wide variety of sequences that are available with MRI. I think one of the most useful sequences I find is these sequences, which are typically called the white blood, but they're really the cine steady-state free precession sequence. Now, it's a 2D sequence, so you have to remember that when you're doing a study, you want to acquire this in the plane you are looking at. So it's important to tailor it to the clinical question and make sure you get the appropriate plane of imaging. Now, this is called by different names by different vendors, as if we were short of acronyms in chest. So you have, it's called as a Fiesta by GE, Philips calls it BTFE, and Siemens calls it TrueFisp. This suffices for most cases, but if you wanted to do quantitative imaging, you have to do what is called as phase contrast imaging. And here are the phase images. They are acquired through the entire cardiac cycle. And if you draw these regions of interest, you can compute what the flow is and what the velocity is. Also, it gives you information about direction of flow. And finally are the more optional sequences, and these are tailored to what specific question you have. So if you're doing it for mass assessment, you want to study the tumor in, say, T1 and T2 characteristics to see what kind of a tumor it is, and you might want to give contrast. But these are optional. And now I'm going to talk about the various planes. As I mentioned, it's very, very important in terms of MRI because you want to make sure that you get the planes that you need because you can't reconstruct it later from the 2D cine sequences. With CT, you get the data in the axial mode, but once you have the data, you want to post-process it in the appropriate plane. And we will start first with the aortic valves. So this was alluded to in the prior talk in the morning as well, where there was a question about pseudoaneurysms of the sinus of valve aneurysm. And that's basically that happens because the axial sections that we obtain are not truly perpendicular to the aortic root or the aortic valve. So what you want to get is these kind of images. These are the oblique axial plane. And you get a nice symmetric appearance of the sinus, and you see the trileaflet valve. The way you get to these images is using the LVOT views. So here are two LVOT images. This is a coronal oblique LVOT plane, and you can see the aortic root very nicely on this plane, as well as a three-chamber plane. Now, the three-chamber is called as the parasternal view in the echocardiography literature. So using both of these, you want to make sure that you remain perpendicular to the aortic root, and these gives you this beautiful pictures of the oblique axial plane and aortic root. Now, one thing I will mention is that I've seen a lot of trainees, and when they start in cardiac CT and MRI, they struggle because once they are trying to generate multiplanar deformations, they've rotated the image so many times that it becomes very difficult to orient yourself. So a very quick way to do it is identify the interatrial septum. Now, this is a scan which was done for coronary assessment, so you can see that the left side has a good amount of contrast. The right side of the heart is pretty much washed out. This is the interatrial septum. Once you see that, then the sinus that points to the interatrial septum is the non-coronary sinus. And then it becomes very easy to identify the sinus to the right will be the right, and to the left will be the left sinus. How about the mitral valve? For the mitral valve, the planes that work best are the four-chamber. This is the short axis at the level of the base of the heart. And here is a two-chamber view of the left heart. And you can see that the mitral valve has been depicted by these red arrows. Now, the mitral valve is a valve with two leaflets, and it has a very unique anatomy. So if you pay attention, it's kind of got a D-shaped annulus. And the anterior leaflet attaches to the straight portion of the D, and the posterior leaflet is kind of a curved attachment to the longer, it's a much longer leaflet for that reason, and it attaches to the curved portion of the D. As we move to the tricuspid valve, you will notice that the planes of assessment are pretty similar. So again, you have this four-chamber view, the short axis view at the base of the heart. The two-chamber right is pretty much a corresponding view of the two-chamber left. So now what you have is the right ventricle here. This is the right atrium with the IVC draining into it. And you also get a part of the outflow and the pulmonic valve here. So in a sense, if you think about it, it's kind of an inflow and outflow view of the right side. Now, this time in the four-chamber view, pay attention to the right side of the heart. This was a patient who had pulmonic stenosis. So as a consequence, the right-sided pressures are elevated. And you can see that the interventricular septum is clearly bowing to the left side. Now, pay attention to the tricuspid valve, and you can identify a dephasing jet, which is extending into the atrium, which is compatible with tricuspid regurgitation. You can pretty much see the same anatomy and the same appearance on the short axis views. You can see the leaflet, and now the jet is actually directed at you. I would suggest that whenever you're looking at any valve or any pathology, as a rule, try and look at it on as many planes as you can. Moving on to the pulmonic valve. And one of the best images or the best planes to look for it is kind of a sagittal oblique. And you can see the pulmonic valve very nicely here. In fact, this was a patient who had pulmonic stenosis and had a pulmonary valvotomy. So as a result, you can see that the main pulmonary artery is quite dilated. The valve opens. There is dephasing at the time of systole, but also there is a regurgitant jet, which you can see right now. So having done the planes of the various planes for cardiac assessment, I'll now talk about the various abnormalities that you can encounter. And I've divided them broadly into two categories. So you have morphological assessment and functional assessment. And we'll start with the valve morphology first. And when you do it, the things that I look for are how many leaflets are there? Are there appropriate number of leaflets, or are they more or less? Any other morphological abnormalities you can see? Are the leaflets thickened or calcified? Are there any tumors? And finally, in cases of endocarditis, you want to evaluate for any perivalvular pathology or complications. So here is the normal aortic valve. Now, in terms of number of leaflets, this is most applicable to the aortic valve. As I mentioned, this is a tri-leaflet valve, and this is a cine image from a CTA, and you can see that the valve opens well and it completely coapts. Now, as I mentioned, in terms of number of leaflets, the aortic valve leaflets can be variable, and they've been reported to range from 1 to as many as 5. And one of the most common forms you will see is a bicuspid aortic valve. This is a true bicuspid aortic valve. The images have been reconstructed from a coronary CTA examination, which was retrospectively gated. And you can see that the valve, there are only two sinuses, and the opening of the valve has got that very characteristic fish mouth appearance. In fact, the leaflets are also thickened and calcified in this case, and the most common hemodynamic abnormality in these patients is usually aortic stenosis. The bicuspid valve comes in two flavors, and this is the second flavor, actually. So here is what is called as a functional bicuspid valve. In contrast to the first one, you will notice that this patient actually has 3 sinuses. So this is 1, 2, and 3. But what's really happened is that this commissure is fused. So between the two adjacent leaflets, the commissure is fused with a raphe, and now what it's doing is that it opens and functions just like a bicuspid valve. So it's termed as a functional bicuspid aortic valve. Again, if you look at it from what we learned just recently, this is the interatrial septum. So this is the non-coronary sinus, and this is the right and the left side of the heart. So it's basically the right-left commissural fusion, which has led to this functional bicuspid appearance. You can have more than 3 leaflets, and this is actually a quadricuspid valve, which I saw on an aorta CT, which we do all gated examinations. So here is the patient with quadricuspid. And to my surprise, in literature, I found this example of quinticuspid valve with 5 leaflets. And this is an example from the Journal of Cardiovascular MR. Now, one thing about aortic valves as they become more than 3, so 4 or 5, is that the common hemodynamic abnormality in these patients is aortic regurgitation, as opposed to bicuspid valves, which tend to be more stenotic. Now, a lot of times these valve abnormalities are already known when you've done the scan, but there will be times when you will be the first one to suggest an abnormality. And actually, this case exemplifies what I'm talking about. This was something I encountered recently. So we had a request for a 17-year-old woman who had a dilated right ventricle. And the clinical question was evaluate the pulmonary venous anatomy, possible atrial level shunt, and the ubiquitous arrhythmogenic right ventricular dysplasia. We seem to have that a lot in our requisitions. So we set off with a big protocol. Now, this is a short axis stack that we did. These are cine steady-state free precession sequences. And sure enough, that the right ventricle is dilated in this patient. I haven't shown you the whole stack, but you can take my word for it. There was no evidence for ARVD. The function was good. There was no focal wall motion abnormality, fat, or fibrosis or delayed enhancement. But what we did found was that the 4-chamber images were very, very useful. Now, if you recollect, when I talked about the 4-chamber images, I said they are best suited for assessing the mitral and the tricuspid valves. So if you pay attention to the mitral valve, it looks pretty good, looks morphologically normal, appropriate leaf thickness, opens well, closes well. But now I want you to direct your attention to the tricuspid valve. And here is a finding that was totally unanticipated, wasn't picked up on echo. So the annotations kind of make it easier, but you will notice that the septal leaflet of the tricuspid valve is significantly displaced apically. So here is where the mitral valve is, but if you look at the septal leaflet, it's apically displaced. And as well, when the valve closes, you can see there is a regurgitant jet. So there's tricuspid regurgitation with apical displacement of the septal leaflet. And this patient has an Epstein's anomaly, which was surprisingly, I would say, not picked up on echocardiography. Now, a word of caution here, though. You have to remember that the septal leaflet of the tricuspid valve is normally slightly apically displaced as relative to the mitral valve. But in this case, if the displacement is greater than 1 centimeter, in this case it's obviously a big displacement, then that goes with Epstein malformation. And you can see because of this displacement or significant displacement of the septal leaflet, a portion of the ventricle becomes atrialized. Now we'll talk about valve masses. And there's a wide variety of masses that you can encounter. You can see vegetations. This is a coronal oblique LVOT image, and you can see a valve vegetation dangling down into the left ventricle. Here is an oblique axial plane looking at the aortic valve. Again, at the right-left commissure, you can see that valve vegetation. Now, important thing to remember, we can see it, yes, but the reason to do a CT or MRI is not to pick up valve vegetations, but more importantly, to look for complications. This is something that we are better at than echo. You can see tumors, and one of the commonest tumors you will encounter involving the valve will be fibroblastomas. And finally, tumor-like conditions. And this is something I'd like to talk about a little bit more, because this is something we're encountering more and more of. So here is a patient. He had a suspected mass in the mitral valve, and this was done on echocardiography, and they wanted to know what that mass was, and we did a cardiac CT for this patient. So here is what was seen on echo. It has circumferential calcification. The center is a non-enhancing core, and you can see it's related to the posterior leaflet of the mitral valve, and it's seen along the mitral annulus. I'll show you another image. This is a 2-chamber reconstruction. And you can again see this mass, which is kind of irregular, but it is well-defined with circumferential calcification, and the center did not enhance. Now remember, this is a very, very typical appearance of caseous calcification of mitral valve. It's a very important condition because it's benign, and we as imagers, cardiac CT or MRI, can actually offer the diagnosis, which can be misconstrued as a tumor on echocardiography. The location is very characteristic. It most commonly affects or is related to the posterior mitral leaflet. The imaging appearance is very characteristic. It's non-enhancing core with often circumferential calcification. Now, most of the times, these lesions are asymptomatic, require nothing, but they can embolize, and in which case they might need operative treatment. And now to the last part of my talk, we'll discuss about functional assessment. In general, when you assess function of the valve, MRI is better because it gives more information. So we'll talk about stenosis and regurgitation now. So here is what valve stenosis would look like on CT. These are reconstructed images of the aortic valve. And you can identify right away that the valve leaflet shows thick clumps of calcifications, abnormally thickened. And if you look at the opening of the aortic valve, it never completely opens. It's a very restricted opening of the aortic valve. So that's compatible with aortic stenosis. Now, MRI can obviously give you this anatomic information, but it can also give you the effects of what happens secondary to aortic stenosis. So here is a 3-chamber view on cine MRI. And you can notice that as a result of the restricted opening, there's a lot of turbulent flow with spin dephasing and loss of signal in the aorta and systole. And also, incidentally, this patient has aortic regurgitation, which you can see as a jet, which is extending from the valve leaflets into the ventricle in diastole. So how do we quantify stenosis? On MRI, you could do it by, like I mentioned, you can do phase contrast imaging for quantification. So if you did phase contrast imaging, you can compute what the peak velocity is, and you can get an estimate of the pressure gradient. The other way is to do a planimetry, and this is possible on both CT or MRI, because what it does is looks at the anatomy. And what I mean by planimetry is, in systole, when the valve is maximally open, you identify the narrowest area between the leaflets, and you draw out that area. So this has been done by different people, and there's been a lot of work on this. And it's been shown to correlate with the degree of aortic stenosis and the pressure gradients. Now, valve regurgitation, again, MRI can show you the regurgitant jet directly, and it can also help you in estimating the regurgitant fraction. So here's an example. This is a patient who had Marfan syndrome. It's a 3-chamber view. So this is the aorta. Just to reorient you, this is the left ventricle, and this is the left atrium. So now we're paying attention to the aortic valve. And you can see when the aortic valve closes in diastole, there is a jet which is directed into the ventricle. So that's compatible with aortic regurgitation. You can see it with this arrow on the still image. Now, if there is one thing I want you to take from this lecture, then this would be it. Please refrain from trying to quantify the regurgitation based on cine imaging. So just by the length and the conspicuity of the jet, I would suggest not mentioning if it's trivial or if it's mild, moderate, or severe. This is because it's so dependent on the MR parameters that you can totally be incorrect. So if you wanted to estimate the regurgitation or the degree of regurgitation, you need to do what is called as phase contrast imaging. And this works very, very well for semilunar valves. So for the aortic and pulmonic arteries, it works very well. And this is how we do it. So you acquire these images throughout the cardiac cycle. You can draw your regions of interest around the vessel that you're looking at. And this generates these kind of flow curves. So here is the baseline. So the flow above the baseline is the forward flow. The flow below the baseline is the backward flow. And then the computer will give you what the regurgitant fraction is. How do we look at regurgitation on CT? So on CT, what we're doing is just looking at the anatomical correlate of this. So now the valve leaflets do not coapt, and that's the reason the patient's having regurgitation. So here is a coronal oblique image, and you can see that the leaflets never completely come together. And here is the oblique axial cine image, where again you can see there is always a small triangular regurgitant orifice. So this is compatible with aortic regurgitation on CT. The last thing I want to show you is valve prolapse. In fact, this is the very example I showed you for aortic regurgitation. So valve prolapse is basically the systolic bowing of the mitral leaflet into the atrium. There's a measurement for it, but a lot of time it's based on visual assessment. It's a common cause of mitral regurgitation. And another important pearl would be this: do not call mitral valve prolapse based on 4-chamber imaging alone. That's because of the shape of the mitral annulus I was talking about. You can totally be overestimating and overcalling this entity. you want to always make sure that you look at a 3-chamber view preferably and correlate it with a 2-chamber view. So here is the same example, patient with Marfan syndrome, dilated root. We talked about the aortic valve earlier and the aortic regurgitation, but now I want you to look at the mitral valve. See how the valve prolapses into the atrium. This would be kind of the plane of the AV valve, but this is significantly bowing into the left atrium.